Okay, so we've all been there, right? Stuck in a hospital bed, focusing on getting better. But then that food tray arrives, and you can't help but wonder, is this really going to help me heal?
You know, it's funny because hospital food often gets a bad rap,
Yeah.
but there's actually a lot of thought that goes into it.
Well, that's what we're diving into today, right?
Absolutely.
The thinking behind hospital food. We're going deep into the Espen guidelines.
The European Society for Clinical Nutrition and Metabolism.
Yes. Their 2021 publication. This is like the Bible for hospital nutrition.
It really is a comprehensive set of recommendations for how hospitals should approach feeding patients.
And it's not just about, making tasty meals. It's really about nutrition as a core part of getting better.
Right. It's about understanding the role of food in patient recovery and well-being.
Exactly. So today, our mission, we're pulling out the key insights from those guidelines. We're going to figure out what shapes those meals you see on your hospital tray.
And hopefully by the end of this, you'll have a whole new perspective on hospital food.
You know, I was surprised to learn that it's not just about the food itself, it's about the whole system.
Oh, absolutely. The guidelines talk about the need for structured food facilities within a hospital.
So like the kitchen.
Yes,
Yeah.
the kitchen, the delivery systems, even the ordering process.
It's like they want a whole infrastructure in place.
Exactly. And crucially, there's an emphasis on clear responsibilities.
Okay, so who does what? Everyone knows their role.
Precisely. From the chefs who prepare the meals to the nurses who deliver them to the patients, everyone has a defined part to play.
And that makes a lot of sense because if something goes wrong, you know exactly where to look.
Right. Accountability is key in a hospital setting.
And one thing that really stood out to me was the focus on sustainability,
Yeah, that's a big part of it now.
like using high quality, sustainable ingredients, minimizing food waste. It's like they're thinking about the bigger picture.
They are. They're encouraging hospitals to be mindful of their environmental impact.
And I also noticed they talk about feedback.
They do. Regular surveys on patient and staff satisfaction with the food.
So it's not just a one-way street. They want to hear what people think.
Exactly. They want to make sure the food service is meeting everyone's needs.
You know, this might sound strange, but I found it fascinating that the guidelines actually talk about treating food as part of medical treatment.
Oh, it makes perfect sense when you think about it.
I guess so.
They recommend structured and documented food ordering. Ideally, this is done through computerized medical records.
Wait, so like you'd order your food the same way a doctor prescribes medication?
In a way, yes, because it becomes part of your documented treatment plan.
So they're really saying food is medicine.
Precisely. It's not just fuel. It's an integral part of the healing process.
And that leads us to the different types of diets available in hospitals. It's not just a free-for-all, right?
No, not at all. There's a framework in place.
So what's the starting point?
They recommend at least two basic diets, a standard diet and a hospital diet.
Okay, so what's the difference? Is the hospital diet just, like, fancier?
Not necessarily. The standard diet is for patients who aren't considered at high nutritional risk.
I guess. And the hospital diet.
That's designed to be higher in energy and protein for patients who might be at risk of malnutrition.
I see. So they get a bit more oomph in their meals.
Exactly. And then beyond these basic diets, there are therapeutic diets.
These are for specific medical conditions, right?
Yes. But the important thing is that these therapeutic diets should only be used when there's a clear medical reason.
Right. So you're not just put on a restrictive diet for no reason.
Precisely. And they specifically caution against diets based on food restriction without any solid scientific evidence.
Like some of those fad diets you see online.
Exactly. Those can be really harmful, especially in a hospital setting.
Okay, so we've got these different diets, but a patient's condition can change, right?
Absolutely, it's dynamic.
So how do they keep up with that?
Well, the guidelines recommend regular reviews of the hospital's diet offerings.
Like updating the menu every few years?
Yes, to keep up with the latest nutritional science.
Makes sense.
But even more importantly, they emphasize checking and adapting the nutritional plan for each individual patient every 3 to 5 days.
So they're constantly monitoring how patients are doing.
Yes, they look at how the illness is progressing, how much they're eating, how well they're tolerating the food.
They're really trying to fine-tune things.
Exactly. And they also want to identify patients who might need extra nutritional support right from the beginning.
So like when they're admitted.
Yes, they recommend a nutritional risk assessment using a tool like the GM criteria.
GL.
It stands for Global Leadership Initiative on Malnutrition.
Ah, okay.
It helps healthcare professionals assess a patient's nutritional status and determine if they need a standard or hospital diet from the get-go.
So let's get into the nitty-gritty of these diets. What's the actual difference between a standard and a hospital diet? I mean, in terms of calories and protein.
Okay, so the hospital diet is designed to be more nutritionally dense.
More bang for your buck.
You could say that. They recommend around 25 kilocalories per kilogram of body weight for the standard diet. But for the hospital diet, it's closer to 30.
Okay, so a bit more energy there.
And the protein difference is even bigger. For the standard diet, it's zero point 0.8 to 1.0 grams per kilogram of body weight. But for the hospital diet, it jumps up to 1.2 to 2.0.
Wow, that's a significant increase.
It is, because protein is crucial for healing and recovery, and it's often underestimated in hospital settings.
Makes sense. Now, what about the balance of carbs, fats, and protein? Are those different too?
Yeah, the proportions shift a bit.
So for the standard diet,
They recommend 50-60% of total daily energy from carbs, 30-35% from fats, and 15-20% from protein.
okay, so that sounds pretty similar to general healthy eating guidelines.
It does. But the hospital diet prioritizes more energy and protein.
So less carbs, more fat and protein.
Right. They bump the protein up to 20%, fats to 35-40%, and carbs go down to 45-50%.
It's all about fine-tuning those ratios to help patients recover.
Exactly. Now, they also talk about something called dietary enrichment.
What's that? Like adding spunkles to your mashed potatoes?
Not quite. It's more about boosting the nutritional value of regular foods.
So like adding protein powder to a smoothie.
Yeah, that's a good example.
Or maybe extra healthy fats to their meals.
Exactly. It's a way to help patients reach their nutritional goals without necessarily having to eat completely different foods.
And they also recommend more frequent meals.
Yeah, even up to 6 times a day.
3 meals and 3 snacks.
Precisely. It helps to spread out the calories and protein throughout the day.
Makes it easier to digest and keeps those energy levels stable.
Exactly.
Yeah.
Now, what about specific groups like cancer patients who might be malnourished? Does nutritional therapy really make a difference for them?
That's a good question.
Well, the evidence suggests that it can.
How so?
Studies show that nutritional therapy can lead to improvements in body weight and overall energy intake in cancer patients.
So they're getting more of the nutrients they need.
Yes, and it can even improve their quality of life during treatments like radiotherapy.
That's really encouraging.
It is. But the impact on longer-term outcomes like survival is still being studied.
So more research is needed there.
Yes. But overall, nutritional therapy definitely plays a positive role in cancer care.
Now, let's talk logistics. Getting the right food to the right patient at the right time.
That's a crucial part of the whole system.
The guidelines emphasize between meal snacks. Why are those so important?
They help prevent long periods of fasting, especially overnight.
Which is important for everyone, but even more so for older adults.
Exactly. For older adults, they aim for less than 10 hours between dinner and breakfast.
That seems reasonable.
And those snacks shouldn't just be empty calories.
So what's the ideal snack?
A mix of carbohydrates, proteins, fats, and fiber.
So like a handful of nuts and a piece of fruit.
That could be a good option, yeah.
So who decides what goes on the hospital menu in the first place?
It's not just the chefs on their own.
It's a team effort.
Definitely. The guidelines recommend having at least one registered dietitian dedicated to the hospital kitchen.
So they're the ones who take all the dietary needs into account.
Yes. They work with the chefs and food service managers to create menus that meet everyone's requirements.
And hopefully those menus also include some delicious options.
Well, absolutely. They want patients to enjoy their meals too.
And the delivery process matters.
Hugely. It needs to be tailored to the individual patient's needs.
So someone in acute care might need help eating.
Yes, whereas someone in rehab might be more independent.
And then there's protected meal times. What exactly is that?
It's basically dedicated time for patients to eat without interruptions.
No doctors popping in to check on them.
Not unless it's urgent.
So they can actually focus on enjoying their meal.
Exactly. And hopefully eat more of it as a result.
Makes sense. Okay, let's talk about individual needs and preferences. Food allergies, that's a big one, right?
Huge. The guidelines are very clear on that.
What do they say?
Complete exclusion of any proven food allergens.
Yeah.
No exceptions.
And what about religious beliefs and personal preferences?
They encourage hospitals to take those into account as much as possible.
So if someone keeps kosher or halal,
The hospital should try to accommodate those needs.
what about vegetarian diets?
Those should definitely be offered.
But they need to be well planned, right?
Yeah,
Well,
absolutely.
Yeah.
They need to ensure they're meeting all the necessary energy and protein requirements.
no skimping on the nutrients.
Exactly.
Now, what about vegan diets? Are those routinely offered in hospitals?
Interestingly, no. The current recommendation is against routinely offering vegan diets
Why is that?
because of the higher risk of certain nutrient deficiencies.
Like iron and B12.
Yes, those are common ones. And vitamin D and calcium.
And those deficiencies could be especially problematic in a hospital setting.
Right. Because patients are already in a vulnerable state.
Okay, let's dive into some specific therapeutic diets. Gluten-free is a popular one.
It is. But it's important to remember that it should only be used for confirmed cases of celiac disease.
So no self-diagnosed gluten-free diets in hospitals.
Nope. The guidelines actually warn against that
Why is that?
because a gluten-free diet can lead to a lower intake of fiber, and it can also cause deficiencies in some minerals and vitamins.
So it's not a harmless choice.
Not necessarily. It's important to get tested before going gluten-free.
Okay, what about the low FODMP diet that's often recommended for IBS?
Yeah, the low FODMP diet can be helpful for managing IBS symptoms.
Like bloating and abdominal pain.
Exactly. It can really improve a patient's quality of life.
But it's a pretty restrictive diet.
It is. So it's important for patients on this diet to get guidance from a registered dietitian.
Makes sense.
They can make sure the patient's following it correctly and getting all the nutrients they need.
Now, we've talked about the high-energy, high-protein hospital diet. When else is a high-protein intake recommended?
For patients with decubitus ulcers, those are pressure sores.
Those can be really serious.
They can. And a higher protein intake helps with wound healing. They recommend up to 1.5 grams per kilogram of body weight.
Okay, now what about low-calorie diets? Do hospitals ever offer those for weight management?
Generally, no. The guidelines are quite clear that low-calorie diets are not appropriate in hospitals
Why is that?
because they increase the risk of malnutrition, even in patients who are obese.
So weight loss is not the priority in a hospital setting.
Right. The focus is on maintaining nutritional status and supporting recovery.
Makes sense, but are there any exceptions?
Very few. They might be considered in cases of refeeding syndrome for patients with obesity and severe insulin resistance, or in specialized obesity rehab units.
But even then, protein intake shouldn't be reduced.
Exactly. Protein is always key.
What about low-protein diets? Are those ever used?
Not usually. In fact, the guidelines specifically advise against restricting protein in certain situations.
Such as?
For cirrhotic patients with hepatic encephalopathy,
That's a serious liver condition.
it is. And restricting protein can actually make it worse.
And they also advise against it for patients with chronic kidney disease who are hospitalized for an acute illness.
Right. Because their bodies need that extra protein to cope with the stress of illness.
Okay, now what about a diet that's low in fat but high in MCT oil?
That's for patients with chyle leakage.
I'm not familiar with that.
It's a condition where fluid leaks from the lymphatic system, and that fluid is high in triglycerides.
Ah, I see.
So the goal of this diet is to reduce the intake of long-chain triglycerides.
Those are the bad fats, right?
Yeah, and to increase the intake of medium-chain triglycerides, or MCTs.
And those are better absorbed.
Exactly. They go straight to the liver, bypassing the lymphatic system.
So it helps manage the chyle leakage.
Precisely. Now, what about neutropenic diets? You know, those restrictive diets for patients with weakened immune systems.
Yeah, those are pretty common, aren't they?
They used to be, but the latest research actually doesn't support their routine use. Yeah. Studies haven't shown a significant difference in infection rates between patients on a neutropenic diet and those eating a regular diet.
So what's the focus now?
Safe food handling practices, that's what really matters.
Okay, let's talk about low-fiber diets. When are those recommended?
The main recommendation for a low-fiber diet is the day before a colonoscopy.
Ah, to clean out the system.
Exactly. There's some evidence for its use after certain types of colorectal surgery and for managing some IBS symptoms. But for most other conditions, it's not routinely recommended.
Okay, now what about sodium restriction? That's a common one for people with high blood pressure.
For those patients, they recommend limiting sodium intake to no more than 6 grams per day.
So watching the salt shaker.
Exactly. But they also warn against being too restrictive, especially for patients with acute decompensated heart failure.
Too little sodium can be a problem too.
It can. So it's about finding the right balance.
Makes sense. Now, what about patients on corticosteroid therapy? Do they need any specific dietary adjustments?
For short-term use, the hospital diet is usually sufficient.
But for long-term use?
It's important to monitor for side effects like high blood sugar.
And adjust the diet accordingly.
Exactly. Making sure they're getting enough calcium and vitamin D.
And restrictive diets are generally discouraged for those patients.
Right. Because they could increase the risk of malnutrition.
Now, diabetes is so prevalent. What are the key dietary recommendations for diabetic patients in hospitals?
The starting point is either the standard or hospital diet, based on their individual nutritional needs.
So no automatic, sugar-free, everything.
Nope. It's about finding the right balance. And good glycemic control shouldn't mean reducing their overall food intake.
So they still need to eat enough
Absolutely. Snacks with a mix of carbs and protein can be helpful.
for keeping blood sugar stable.
Exactly. And very low-carb diets are generally discouraged.
So less than 40% of their calories from carbs.
Right. That can be too restrictive. For diabetic patients with complications like kidney problems, their diets need to be more individualized.
So working closely with a dietitian.
Yes, and often following something like a Mediterranean or DASH diet.
Those are both heart-healthy diets, right?
They are, and there might be specific recommendations for things like sodium intake, fish, whole grains, fruits, vegetables, nuts, and legumes.
And limiting processed foods.
Exactly. Now, what about those modified texture diets for people with swallowing difficulties?
Yeah, those are important.
They're often recommended for older adults who are at risk of malnutrition and have problems swallowing or chewing.
And they might need them after a stroke, for example.
Yes, or with certain neurological conditions or head and neck cancer.
So it's important to screen for swallowing difficulties in those cases.
Absolutely. And the guidelines encourage the use of the IDDSI framework,
What's
the
that?
International Dysphagia Diet Standardization Initiative.
Okay, it's a mouthful. What does it do?
It standardizes the description of food and liquid textures.
So everyone's on the same page.
Exactly. Now, what about diets after pancreatitis or gastrointestinal surgery?
Those must be pretty specific.
For mild acute pancreatitis, they recommend a low-fat, soft diet when reintroducing food.
Makes sense. Easy on the digestive system.
Right. For chronic pancreatitis, restrictive diets aren't usually needed unless there's uncontrolled steatorrhea,
Which is?
fatty stools due to poor fat absorption.
Ah, got it.
But malnourished patients with chronic pancreatitis often need a high-protein, high-energy diet.
With frequent small meals.
Exactly. And they should avoid a lot of fiber. After gastrointestinal surgery, they usually start with a gradual reintroduction of oral food.
So taking it slow.
Right. But in most cases, they actually encourage early oral intake, even within hours of surgery.
Wow, that's interesting. I thought they used to keep people NPO for longer.
Things are changing. And after lower GI bleeding, they usually resume the standard hospital diet once the patient can tolerate oral food.
And for upper GI bleeding.
Early refeeding with a standard diet on day 1 has been shown to be safe for certain types of ulcers and tears.
And it might even shorten their hospital stay.
Exactly. Now, one final question. Is it ever a good idea to combine multiple therapeutic diets?
It seems like that could get really restrictive.
The guidelines advise against it whenever possible,
Why?
because it significantly increases the risk of insufficient food intake and malnutrition.
So the more restrictions, the harder it is to get all the nutrients you need.
Precisely. And that brings us back to the importance of constantly assessing food intake.
Making sure patients are actually eating what they're supposed to.
Absolutely. That's a crucial part of nutritional care.
And they recommend intervening if a patient isn't meeting their needs.
Yes, if someone in nutritional risk is consistently eating less than half their estimated energy needs for more than 3 days, that's a red flag.
Time to reassess and maybe make some changes.
Exactly.
Well, this has been quite a deep dive into the world of hospital nutrition. I have to admit, I had no idea how much thought goes into those seemingly simple meals.
It's a complex system, but it's all driven by a commitment to patient well-being.
And even though there are still some research gaps, these guidelines provide a really solid framework for nutritional care in hospitals.
They do. And I think it's empowering for patients to understand these principles.
So they can advocate for themselves and have informed conversations with their healthcare team.
Exactly. Now, here's something to ponder. With the growing awareness of how crucial nutrition is for recovery, how do you think hospital food practices will continue to evolve in the future?
Yeah, that's a great question to leave our listeners with. What might hospital food look like in 5 or 10 years? Will it be more personalized, more appealing, more focused on individual needs and preferences?
I think that's definitely the direction things are heading in.
And I, for one, am excited to see what the future holds for hospital food.
Me too. It's an area that's ripe for innovation.
Thanks for joining us on this deep dive. We'll be back next time with another fascinating look at the world of nutrition.
See you then.